So one of the things I presented here at this meeting was an update on the MURANO study. So this is a comparison of time-limited venetoclax and rituximab compared to bendamustine and rituximab in relapsed and refractory CLL. We'd published the primary endpoint showing the superiority of venetoclax and rituximab, and so the interest with ongoing follow-up is really around the outcomes of the patients in the venetoclax rituximab arm, in particular what happens after cessation of treatment. So the design of this trial is that all patients on the venetoclax arm would cease treatment at a fixed time point of 24 months. So we have the update here now with 4 years of median follow-up and as well some genomic analyses. We'll talk about the genomic issues first of all. So unlike what had been revealed with single-agent venetoclax, at least in this trial with 194 patients, there was no differential outcome by the presence of TP53 mutations. So with 4-year follow-up to date, with or without mutations, no difference in outcome. Similarly, other mutations that had been adverse in the chemotherapy era, SF3B1, BRCA3 or Notch mutations, also so far are not showing any inferior outcome with venetoclax. So it looks as though there may be beneficial effects in those high-risk groups. An emerging indicator of adverse outcome is those of high genomic complexity. We didn't have karyotype here, and this was measured by array looking at genomic aberrations. Patients with no aberrations, or with what we call low complexity, 3 or fewer aberrations, are doing equally well. However, the 10% of population in the venetoclax arm with high complexity, 5 or more abnormalities, have an inferior outcome. This is reproducing what we're seeing with most of the targeted agents, where high genomic complexity identifies a high-risk group. So it remains to be seen what the optimal approach for that small but important subset of patients is.